And today's modular program is about mechanical ventilation, episode 112. And I would like to invite Dr. Ratan Gupta, Dr. Sanjay OP, Dr. Arjun Alva, and I will be with you all through the meeting. And I also have seen Dr. Jayashree Sood in the meeting. Thank you for joining, madam. And I would like to hand over the podium to Dr. Ratan Gupta. Ratan Gupta is our consultant, senior consultant in cardiac critical care. Sanjay OP is again an accomplished cardiac critical care intensivist. Arjun Alva is a critical care specialist. And I will be with you. I'm the Director of Academics at Narayana Hrudayalaya, Bangalore. And we have interesting session today. And Dr. Ratan Gupta, please conduct the meeting. And the questions will be at the end of the session. And please feel free to comment or pose questions to the panelists and the speakers in the chat box provided. Thank you very much. And Dr. Ratan Gupta, please.
Good evening, sir. Thank you. Today's topic is basically related to mechanical ventilation through tracheostomy. And I invite Dr. Nitya to share her slides. She's going to speak on tracheostomy, the indications for tracheostomy in respiratory failure. And she will also talk about the different techniques available for percutaneous tracheostomies. Dr. Nitya Chaya. Dr. Nitya is a consultant in critical care medicine at Manipal Hospital, Whitefield. She is an anesthesiologist by training, and she has done her FNB critical care and EDIC. And she is having special interest in ECMO and critical care ultrasound. And she is also interested in infectious disease. Dr. Nitya, please go ahead with your presentation.
Thank you, Ratan sir, for the kind introduction. I'll be talking about the tracheostomy for respiratory failure, indications and techniques. As we all know, tracheostomy is a process where we create an opening in the anterior wall of the trachea through which a tube can be inserted or just a stoma can be created. And this facilitates airway access and ventilation in patients, either mechanical ventilation or spontaneous. It is very interesting to know that the first description of tracheostomy was done as early as 2000 BC in some old Hindu scripts, as well as in some Egyptian documents. So the first modern tracheostomy was done in 1546 by Antonio Musa Brassavola, a surgeon. So this was mainly done for airway obstruction due to enlarged tonsils. So coming to the indication for tracheostomy, we can classify this into emergency and elective. Emergency will be upper airway obstruction due to any cause and where there is difficult intubation. And elective prolonged mechanical ventilation in a patient with respiratory failure, that is the commonest indication of an elective tracheostomy. Also, it can be done when there is a difficulty in weaning a patient off ventilator support. Also, if the patient has some neurological condition where the airway control is poor, and if they require tracheobronchial toileting or secretion management, tracheostomy should be done. And also sometimes permanent airway control in malignancy or trauma conditions, the tracheostomy should be done. So coming to the contraindications, so absolute contraindication for tracheostomy is, especially for an elective tracheostomy, is when an informed consent is not available. And also extensive cellulitis in the anterior part of the neck involving the trachea, and sometimes uncorrectable bleeding diathesis. Coming to relative contraindications, when the patient is hemodynamically unstable, we should not go for an elective tracheostomy. And also when the patient is very hypoxemic, requiring an FiO2 of more than 60% and PEEP of more than 12. So coming to respiratory failure, so there are certain questions which need to be answered, like which patients in respiratory failure need tracheostomy, and when should this tracheostomy be performed in these patients, and what are the benefits due to the tracheostomy. So answering the first question, which patient should require tracheostomy? So any patient who requires any patient with respiratory failure who requires prolonged mechanical ventilation, tracheostomy should be done. But we should remember that it should be done only in a patients in whom we expect a meaningful recovery. If the patient is very unstable and probably not going to survive, there may not be any point going for a tracheostomy. So the question arises, how do we decide which patients require prolonged mechanical ventilation? So what is found is just clinical judgment. It is like there are some studies which are done, which is shown that if we go for an early tracheostomy, a lot of patients have received unnecessary tracheostomy. That means if we wait for a longer duration, they may not even require a tracheostomy. They may just be extubated. So it is a difficult question to answer. And if we keep the patient on elective ventilation for a long time without a tracheostomy, they may be subjected to endotracheal intubation for a prolonged time, and the weaning process may be prolonged. So this is a difficult question to answer, and it will be dealt in detail in the next talk. Also, coming to when during the course of mechanical ventilation should the tracheostomy be performed. So there is something called early tracheostomy and late tracheostomy. Both of them, there's no definite number of days to be called early or late. Different studies have used different criteria. But on an average, we can say that early tracheostomy is like within 10 days, like 7 to 10 days, and late tracheostomy is after that. And it is certain benefits are found with early and late tracheostomy also. What are the benefits in the terms of patient outcomes associated with tracheostomy? So it is found that in early tracheostomy, patients have the lesser duration of mechanical ventilation, lesser duration of ICU stay, and hospitalization. This is what is found in few studies. And also because of this lesser duration of ICU stay, there is lower medical care costs. Also, it is found that early tracheostomy may benefit certain patients like with stroke, head injury, spinal cord injury, but in patients with respiratory failure, the benefits are not very clear. Other question is whether tracheostomy reduces the VAP rates. So this is also a controversial topic. The studies have not shown any clear benefit for this as well in patients who undergo early tracheostomy. Some advantages are patient comfort. Definitely, tracheostomy provides more comfort to the patients. So because of this, the requirement of sedation is less, and this facilitates weaning from the ventilator. Also, the airway resistance is reduced, and the work of breathing is also reduced in patients with tracheostomy, which facilitates weaning. So there is no proper studies, no good quality studies, no uniform studies to say that like certain benefits like VAP, weaning of the duration of hospital stay, whether the benefit is definite or not. More studies are required in this aspect. So coming to the techniques of tracheostomy, so there are two major techniques. One is open surgical approach and the other is the percutaneous approach. So open surgical approach is done by the surgeons in the operation theater, whereas the percutaneous dilatational tracheostomy is done by the intensivist or the anesthetist in the bedside. So which technique do we go for? This depends on your institutional preference, your expertise in this procedure. But nowadays, more and more places are going for percutaneous dilatational tracheostomy, and probably in future this will be considered the procedure of choice. The studies have not shown any major difference in the bleeding or long-term complication between the two procedures, open and the surgical approach or the percutaneous approach. Some studies, some meta-analysis have shown that there is reduced wound infection in patients undergoing percutaneous dilatational tracheostomy. Also, because this is done in the bedside, it can be done faster, and also the cost of percutaneous tracheostomy is lower in most institutions compared to surgical tracheostomy. So these are the advantages of percutaneous dilatation tracheostomy. So there are certain relative contraindications to percutaneous tracheostomy. So in patients with emergency airway access, it may not be the technique of choice. But having said that, even patients with emergency airway access, depending on the institutional comfort and the person who's doing it, it can be done in emergencies as well. And in patients with difficult anatomy, if the neck is distorted, there's a hematoma, large tumor, then sometimes percutaneous technique may not be feasible. If there is limited neck movement like cervical fusion and cervical spine injury, again, this is a relative contraindication. And aberrant vessels in front of the neck, especially high riding innominate artery, it is a relative contraindication. Previously, even morbid obesity and short neck, the percutaneous tracheostomy was considered a contraindication, but of late, their studies have shown that this can be safely done in patients with morbid obesity and short neck. In fact, sometimes because when we're using ultrasound and ultrasound, they say it might be better than the surgical tracheostomy as well, tracheostomy also. And then in patients with coagulopathy thrombocytopenia also, previously it was considered a relative contraindication, but now it can be easily done after correcting the parameters. So the number of contraindications for percutaneous tracheostomy has reduced over the years. So what are the techniques of percutaneous tracheostomy? So there are many techniques which are described in the literature. I will be dealing with three main techniques. So one is the Ciaglia multi-step dilation technique with sequential dilators. Here, all these techniques are semi-Seldinger techniques where the guide wire is passed and then the trachea is dilated. So here, multiple dilators are used to dilate the trachea. Ciaglia blue rhino single step dilatation with the curved dilator. This is the most commonly used technique. So as you can see here, so there is a curved dilator which can be used to dilate the trachea. Here it is a single step process. The only problem is the force required to dilate the trachea may be more with this dilator. The other technique is using the dilating forceps called the Griggs forceps. So here a guide wire is put and over that the Griggs forceps is passed and then the trachea is dilated. So here sometimes the trachea may be open too much because it is we don't have a dilator per se, we have to dilate with the dilating forceps. So out of these three techniques, the most commonly used is the Ciaglia blue rhino single dilator technique. So this tracheostomy, when we do it, we can do it either with the help of a fiber optic bronchoscope or ultrasound guided or landmark technique. So landmark techniques, it is like we look at the landmarks, mainly the thyroid cartilage, cricoid cartilage, and sternal notch, and then the tracheostomy preferably should be done between the second and the third tracheal ring. So just with palpation, we do the tracheostomy will be done. And the other technique is the ultrasound guidance. Here, before doing the tracheostomy, we can do an ultrasound of the neck and identify the vascular structures and then go ahead with the tracheostomy, or it can be done real time, just looking at the structures and then going real time. So especially in obese patients and patients with distorted cervical anatomy, or if they have or any difficulties in the procedure, these are helpful because they help us to identify the structures in front of the neck. So the studies have found that compared to the landmark technique, the first pass success rate with the ultrasound guided technique is more. Also, avoidance of the damage to the vascular structures in front of the neck can be avoidance. Yeah, it can be avoided. Another technique is the bronchoscopy guided technique. So here, the advantage is the appropriate site of tracheal puncture can be identified, and also real-time entrance of the needle into the trachea. So the bronchoscope will be positioned inside the trachea. So the entry of the needle into the trachea can be visualized. the advantage mainly over the other techniques is that it avoids the posterior tracheal wall injuries. And also, once the tracheostomy tube is inserted, the bronchoscope can confirm the position of the tracheostomy tube by direct visualization. The disadvantage is that it does not identify the cervical anatomical structures, and also because of the introduction of the bronchoscope through the ET tube, there can be hypoxemia, hypercarbia, raised ICP can be seen, which may not be preferable, especially in patients already who have a neurological condition. And sometimes the bronchoscope can be damaged by the introducing needle. The studies have found that both ultrasound guided technique and also bronchoscopic guided technique are equally safe, and the complication rate is similar between the two techniques, whereas the landmark technique has more complications. So how do you do the tracheostomy? So it's always better to have a checklist. So you keep a checklist for the tracheostomy and make sure that all the tracheostomy instruments required for tracheostomy is available in the bedside. The airway card should be there, airway backup should be there. ETCO2 is required. Also, 2 clinicians should be there, especially if we're doing a bronchoscope guided technique. Airway nurse or respiratory therapist should be available. The patient should be well sedated and paralyzed with a neuromuscular blocking agent. After that, the patient should be positioned. So while positioning the patient, we can keep a roll on the shoulder and then give some neck extension to the patient. So after that, the endotracheal tube can be pulled out so that it does not come in the way of the tracheostomy tube. So if you're using a bronchoscope guided technique, so here the bronchoscope can be positioned at the tip of the ET tube, and then under vision, the ET tube can be pulled out. If you're using an ultrasound guided technique, you have to do it under ultrasound guidance and then pull it out a little so that it doesn't come in the way of the introducing needle. So this is the blue rhino. This is the one we use in our institute. So I will just show you a video of how we do tracheostomy in our institute with, So we use the ultrasound guided technique. We do not use bronchoscope. So first we look at the structures, make sure there's no vascular structures in the front part of the neck. And then once we use the sterile precautions, then we mark the point, like preferably between the second and third tracheal ring, where the point of entry is marked. Then after that, local anesthesia is given, and then some saline should be taken in the syringe and then attached with the introducer needle, and under ultrasound guidance, we locate the trachea, and after that, the guide wire is passed into the trachea, following which we confirm the position. Here we can see that it is between the first and second tracheal ring in this thing. Once the position is confirmed, initially a skin nick is done, and then a small dilator is first passed into the trachea. Following that, the blue rhino is passed and dilated. Up to the black mark, we have to pass the blue rhino and then dilate. So once this is done, the next step will be to put the tracheostomy tube into the trachea. Once that is done, we connect the ETCO2 and confirm the position of the tracheal tube. If you're using a bronchoscopy guided technique, then the bronchoscope itself can be introduced, and under vision, like directly, it can be confirmed. So here we do it with the ETCO2. Okay, yeah. So to summarize my talk, respiratory failure is the commonest indication of tracheostomy in the ICU. So percutaneous tracheostomy is better, but then institutional preference and expertise of the person doing the tracheostomy also should be considered. Ciaglia single step dilatation is preferred nowadays, but different methods can be used to do the tracheostomy. And preferably do the tracheostomy under ultrasound guidance or bronchoscopy guidance. Nowadays more and more institutions are using bronchoscopy guidance over ultrasound guidance, but both have equal complication rate, and there is no benefit of one over the other as per the literature. Thank you.
Thank you, Dr. Nitya. That was a wonderful presentation, very lucid. The questions will be taken at the end of the session. Now I want to introduce Dr. Arjun Alva. He's a consultant intensivist at Narayana Health. And Arjun, please introduce the next speaker.
Thank you, Ratan sir. So next speaker is Dr. Rajavardhan. Dr. Rajavardhan has been consultant critical care medicine at Whitefield Manipal Hospital. I know him since he's been quite actively involved in educational activities for ECMO. He recently conducted a very successful ECMO workshop as well at Manipal Hospital. Congratulations, Rajavardhan. He will be taking over the next topic regarding the tracheostomy, and he will be talking a little bit more regarding tracheostomy and tracheostomy for respiratory failure and its controversies. Yeah, over to you, Rajavardhan.
Thanks, Dr. Arjun, for the nice introduction, and thanks, Dr. Muralidhar, Kanchi, and ICA for the invitation. Today, I'll be talking on respiratory tracheostomy for respiratory failure controversies. No disclosures. Okay, I'll be talking this topic. I'll be dividing this topic into three parts. Mainly, one is insertion-related controversies. Second is maintenance and weaning, and decannulation. Okay, during insertion-related topics, there will be a slight overlap between mine and Nitya. So I'll just try to skip those topics. I'll try to finish as early as possible. First one is insertion-related. I'll be talking about timing. Next is who should do it, where should we do it, which technique is better, does guided tracheostomy makes any difference, can PDT, that is percutaneous dilation tracheostomy, can be done in high-risk patients. Okay, timing per se, from the historical perspective, when we started getting understand that tracheostomy can be done in a patient with prolonged ventilation, that is the concept which arrived in 1970s. Initially, they said that anything 3 to 4 weeks of mechanical ventilation, we can consider tracheostomy. With better understanding of tracheostomy in 1980s, there was development of new pressure curve. They started to know that we can decrease the complication, and in the meantime, percutaneous tracheostomy was introduced. Then in 1990s, with this all this understanding, they felt that it can decrease the timeline. Don't need to wait for 4 weeks. We can come down to 21 days. This is the time where mainly ENT people are doing tracheostomy. So with the arrival of percutaneous tracheostomy with intensives coming to role, in 2005, they said that 21 days, definitely we should do it. But whether we can do it earlier, between 10 to 10 days, 21 days was the question. Okay. This they try to solve with multiple systematic review and analysis, but it's still a question at that point of time. With further evidence is coming in 2013, one more meta-analysis came by Sean et al. It is almost 2037 patients were there from 6 studies, but you should understand that most of the tracheostomy studies till then, they're more of observational studies or retrospective studies. Okay, this is a collaboration of both retrospective and observational studies. Here they divided tracheostomy into early versus late. This is in 2013. They found that there was a decreased mortality, VAP incidence was there, decreased duration of ventilation with early tracheostomy. Okay, but as I told you, these are more of observational studies. Then in 2012, in the meantime, there's one more study came. It mainly involved trauma, surgery, and spine surgery, spine injury patient or neuromuscular disease patient. In this, they did early tracheostomy versus late tracheostomy. They considered 4 days versus 6 days. This is for a trauma or a surgical patient. They found that there's a decreased VAP incidence, there is a decreased duration of ventilation, and shorter time of hospitalization. But as I told you, this is mainly for trauma patient or a neurosurgery or neurological patients. Okay. When all these things are going on, one more thing was developing in the field of critical care. What is VAP exactly? Initially, whatever the clinicians said, they used to go by the word of clinicians. It is VAP. In this meantime, they felt that clinicians are over-diagnosing VAP. They decided that better to make it a subjective rather than better to make it an objective rather than a subjective definition. So CDC came with the definition. They included PEEP, they included change in the PEEP, they include WBC, they included microbiology, but they excluded chest X-ray and secretions in the definition. But when they correlated during the autopsy, whatever the definition, either a CDC definition or CPS definition, none of them are able to correlate good with diagnosis of VAP. So VAP definition per se has been a major controversy. So because of this controversy per se, no clinician or no definition is able to diagnose VAP. So always, whenever after this, or once this definition came, whenever anybody has done a study, they're not able to find any significant difference in VAP in most of the studies after this. So one of the major trials came after this, during this time was TrackMan trial. Okay, it is also came in 2013. It's a multi-center RCT done in Italian ICUs. Almost 70 ICUs are involved. Here they felt that if patient is expected to stay on ventilator for more than 7 days, they'll do tracheostomy as early as within 4 days or latest 10 days. Then they found that mortality, no difference was there, definitely. VAP, as usual, it became inconclusive. ICU length of stay was also inconclusive in this. But important thing is ventilator free days were more in case of early group and need of sedation was less in early group. Okay. So I understand this, it will cause some benefit. Whether it will cause any harm, I think this topic was also covered by Nitya. They noted that only 45% of the patient in late group, that is, if 100 patients are supposed to go in tracheostomy in the late group, only 45% of the patient require tracheostomy. So then comes whether we are causing harm by doing unnecessary procedure for this patient, especially there was some harm because complication rate was almost at 6%. So it comes to a question whether we should do it or not. But at the end of the day, these studies definitely will measure complications and all, but one thing it will not measure is patient comfort. Okay, patient was much more comfort on tracheostomy. We were able to get out of ventilator. We were able to decrease sedation. Whether that will amount to anything, so that's a question we have to address in further studies. Okay. Next question is who should do it? Okay. Then comes intensivist versus surgeon. Both of them are trained enough to do it. So they did a study. In intensivist, it can be divided further into anesthesiologist, pulmonologist background, and a medicine background. In surgeon, ENT, and others. They found that there's no difference in the complication rate, whether it's an intensivist or a surgeon. Both are good enough. Only thing they noted is if a pulmonologist is an intensivist is taking a decision for tracheostomy, there is a delay in decision making by pulmonologist. Okay. You should. I'm also assuming here intensivists generally do a PDT, whereas surgeon do a surgical tracheostomy. So when an intensivist does, it is faster at bedside. It is faster, and there's no delay in the OT time. Okay. Next comes which one is better, surgical tracheostomy or PDT. The complications during the procedure can be divided into major and minor. Major complications were more or less same. There is no difference. Minor complications, wound infection and scarring were more with surgical tracheostomy, and scarring was more with surgical tracheostomy. Whereas in PDT group, the chance of having a false passage and bleeding were more. These are minor complications. Then duration and cost. Surgical tracheostomy, it was more, whereas it is less in PDT. Okay, this topic has also been dealt. Different techniques of PDT, I'll not go into detail. Main thing is with multiple dilator technique, they found that there's an increase in minor complication and increased duration. Whereas the Ciaglia technique, they found that it is most safest technique, but the only thing is you should have enough strength in your arm. If you don't have, please hit the gym now only. Okay, next is Griggs technique. Here, major complication rate was 4.4 times, and invariably it will lead to an overdilation. So better Ciaglia Raynaud technique is preferred, single pass. Okay. Then different techniques, as Nitya discussed already, FOB guided, USG guided, and landmark guided. FOB guided is considered as gold standard. It's a classical teaching. Only thing is increased duration was noted in FOB guided. Then USG guided, there are a lot of evidence is there, and it is made famous in our own Bangalore by Dr. Jose Chaka, which is practiced in most of the hospitals in Bangalore. It is safe as FOB guided. Major advantages help in identifying anatomy as well as any major blood vessels which is present in front of the trachea. Landmark guided is also okay, but only thing is complication rates were more and more puncture was needed to get into the trachea. Okay, it doesn't matter at the end of the day which technique you do. Make sure that you practice enough. At least do 20 under supervision. Then you should be able to practice on your. That is the guideline by American College of Chest Physicians for tracheostomy. Okay. High-risk patient, basically high-risk patient, I refer to coagulopathy and morbidly obese patient. Here they found that it can be safely done in both, but in case of morbidly obese patient, usually people had preferred FOB guided procedure, But some of the times it has to be abandoned because they are not successful in doing the procedure. So invariably, some of them will be get translated into surgical tracheostomy in case of morbidly obese. Next, I'll go to the maintenance of tracheostomy. So maintenance of tracheostomy can be divided into protocol-driven care and the usual care. What do you mean by protocol-driven care? Here, in case of protocol-driven care, there are three protocols we have. We have a weaning protocol, we have a swallowing protocol, and a decannulation protocol. Whenever we use a protocol-driven care, the time to decannulation was much less compared to an usual care which is done. Okay, in case of protocol-driven care, it was 5.7 days on average, whereas in usual care, it is 15.5 days. So other thing is, in swallowing protocol also, there are two kinds of protocol, whether FEES, that is functional endoscopic evaluation of swallowing, versus clinical assessment of swallowing. If you use FEES, there's higher chance of decannulation compared to clinical assessment of swallowing. Next, who should take care in the ward? Okay, whether a dedicated tracheostomy team is required or a usual care is okay. Dedicated tracheostomy, it can vary in the team can vary in the anatomy. It can be an ENT specialist or a respiratory therapist, intensivist, pulmonologist, and a salt is swallowing and language therapist. It can vary depending on the institute. They found that if we have a tracheostomy team, there is a reduction in total tracheostomy time as well as increased speaking valve use if you have a dedicated tracheostomy team. Okay. Then one more study came whether having an intensivist as a part of tracheostomy team, does it make any difference? Okay. It can be divided in intensivist-led tracheostomy team and tracheostomy service group per se with varying content, and then routine care. So when they notice that if an intensivist is involved in a management of tracheostomy, the decannulation rate before discharge was 26%, whereas in tracheostomy service group, it was 14%, and routine care, it is 8.2%. And oral diet before discharge was initiated in 46.4% compared to 35% and 26% in the other group. But there is no difference in the median length of stay. Okay. Last topic is decannulation. It can be divided. There are different techniques for decannulation. One is caulking, just by blocking with a narrow size tube, tracheostomy. Second one is by downsizing and blocking. Means if patient is having 8.5 tube, we come down back gradually, cuff takes 1.5, then use a cuffless fenestrated tube and see. Caulking is mainly done in case of patients who are on a short-term ventilation and with no neuromuscular weakness, whereas downsizing and blocking is done in case of long-term ventilation, neuromuscular weakness patient. Then one more technique which is becoming more and more popular recent days is single-stage decannulation protocol, where what we do is we just deflate the cuff, assess, you do all the swallowing protocol and all, and then you decannulate it in a single step. Okay, they found that it is a safer alternative, and this is a step which is widely used in our institute also. So my take-home message will be: early tracheostomy can be done as early as 4 days in case of neurology or neurosurgeries or spine surgery patients. In medical patients, better to wait at least 10 days. Trained intensivists can do tracheostomy. It can be done at bedside. Percussion tracheostomy is a safe procedure. USC or FOB guided is always better. Can be done in complicated patients in obese as well as coagulopathy. Protocol-driven care is always better. Tracheostomy should involve a multidisciplinary team, intensivist-led team, or associated earlier decannulation. Single-stage decannulation can be safely done in a short duration ventilated patients. Thank you.
Thank you, Dr. Rajavardhan, for a very good presentation. We will take questions for Dr. Rajavardhan at the end of the presentation. At the end of all the presentations. Okay, now I would like to introduce Dr. Sanjay OP. Dr. Sanjay OP is a senior consultant cardiac intensive care unit at NH Health City. He is also the director and head of adult ECMO services for NH Health City. He is also the go-to person and one of the experts in post-operative heart and lung transplant. And he is, again, a dynamic personality himself. Dr. Sanjay OP, I would like you to introduce the next speaker, Dr. Vimal Bharadwaj, please.
Thank you, Arjun, for the introduction. Take this opportunity to introduce Vimal. Vimal is one of our dynamic consultants who looks after surgical and medical critical care at NH Health City. His pet subjects are ultrasound, and he's very good at it. He's got notable publications to his name. Without much ado, over to Vimal. The stage is yours now, Vimal. Over to you.
Thanks a lot, sir. Thanks for the presentation. Yes, sir. Thanks for the introduction. It's a pleasure to join again. So I'll be talking about VV, ECMO, the indications and the cannulation techniques. As we all know, shock is nothing but a mismatch between oxygen delivery and consumption. So when this fine balance is dysregulated by any of the pathological states, and the conventional modalities of treatment do not ensure a safe matching between the two, then the extracorporeal therapies have to be considered. So this slide depicts the oxygen consumption, which is 20%. So it boils down to the delivery and oxygen consumption ratio. In a normal, healthy individual, the DO to VO2 ratio is 5:1. But because of any disease pathology like sepsis or hypermetabolic state, when the oxygen consumption increases, and because of other factors, when the oxygen delivery also starts coming down, the ratio of 2:1, I repeat, the ratio of 2:1 is an important figure to be taken notice of. So when the ratio is 2:1, then it can lead to the metabolic acidosis, lactic acidosis, thereby causing organ damage. And once this process is not curbed, then it can lead to a vicious cycle of organ damage and thereby slipping into multi-organ failure and eventually death. So these extracorporeal therapies are very good at maintaining this DO to VO2 ratio. If in ideal cases, in ideally potentially reversible cases, when started early, then we can have better DO to VO2 ratio, thereby ensuring the time to get rid of the primary pathology and thereby having optimal outcomes. That's why timing is the key. So before the patient slips into irreversible organ damage, we need to consider extracorporeal therapies if the conventional modalities of treatment are causing organ damage by itself. For example, in a case of severe case of ARDS, the lung is quite damaged and the lung is very, very non-compliant. Even as 4 to 6 ml per kg of tidal volume can lead to very high plateau pressures and thereby causing biotrauma as well. Then it is prudent to start the ECMO as early as possible to prevent the vicious cycle of organ damage. We will be dealing with VV ECMO in this session. So VV ECMOs are used once there is a respiratory failure. Just to have a better understanding, I will show you one of the figures over here. So it's nothing but the veno-venous ECMO. The drainage cannula over here removes the blood from one of the large veins. From here, it's a femorojugular circuit, dual cannula circuit. So the drainage cannula removes the blood and it gets oxygenated, and via the return cannula, the blood is given back to the superior vena cava and thereby into the right atrium, right ventricle, from there into the pulmonary circuit, and then it goes into the left heart. So in order for the oxygenated blood to be delivered into the systemic circulation, we need to have non-compromised cardiac output or a normal cardiac output. So VV ECMO is predominantly in case of oxygenation or ventilatory failure. Oxygenation and or ventilatory failure. Wherein with the conventional mechanical ventilation, if it is not achievable to give a safe oxygen and carbon dioxide removal, then we need to consider this VV ECMO. Now, coming to the indications. The most important indication is the potentially reversible severe respiratory failure. For example, every center have got their own protocols. So just to have a number, PF ratio of less than 50 millimeters of mercury for more than or equal to 3 hours, or PF ratio of less than 75 millimeters of mercury for more than 6 hours of conventional mechanical ventilation, then you can consider VV ECMO. The Murray score or the lung injury score of more than 3, uncompensated hypercapnia with a pH of more than and with a pH of less than 7.2, even with a very high respiratory rate of 35 breaths per minute, then also it's an indication for VV ECMO. In other conditions like severe aortic syndromes and those patients who are on lung transplant list and they have got severe respiratory failure, so as a bridge to transplant, one can consider this therapy. And in case of pulmonary embolism, blocked airway, unresponsive to the therapies, then also you can consider VV ECMO. And these are the indications that have been recommended from NHS during the COVID-19 pandemic. So unsuccessful trial of ventilation in the prone position for 6 hours. Then, so this is what we routinely follow in our institution. So if the patient is not responding to in prone ventilation, even after 3 to 6 hours, and continues to have persistent respiratory acidosis, severe respiratory acidosis, and very low PO2 FiO2 ratios, then we do consider ECMO in potentially reversible pathologies. So in cases with unsuccessful optimal respiratory management with lung protective ventilation, so this is from the NHS and the Murray score of 2.5 to 3. We need to know what are the contraindications more than the indications. So indices of low potential to recover with a RESP score, which is a short form of a respiratory ECMO survival prediction score of less than 3. A RESP score of less than 3. So this is the RESP score. It's an amalgamation of various strategies, which includes age, immunocompromised patients, mechanical ventilation, ARDS patients, CNS dysfunction, and associated infections, neuromuscular blockade before ECMO. So this is an amalgamation of various other factors that they take into the consideration. And if the combined score is more than 3, then the outcomes are better after initiating ECMO. If the combined score is less than 3, then the outcomes are worse after initiating ECMO. So RESP score is something that can be used on a priority basis in every ECMO center. And those who are receiving invasive mechanical ventilation for more than 7 days, then also the outcomes are worse because the incidence of fibrosis is quite high and they are more prone for septic shock, then also the outcomes are much better. The clinical frailty scale category. This I would advocate along with using with the age. So age is not an absolute contraindication. Age along with clinical frailty scale. So that is, this gives an insight into the patient's functional status, whether the patient, how active the patient was before contracting the illness. So based on that, one can take a call on initiating the ECMO. So if the patient was not very active, bed-bound, then the outcomes are very poor in this set of patients. So ECMO is a costly modality. Apart from the costly modality, we are taking the blood out on oxygenating and giving back to the body. So it has got its own repercussions. So we need to choose the ideal patients to get the optimal outcomes. And if the cardiac arrest for more than 15 minutes, obviously with severe neurological injuries, so all these get covered in RESP score itself. And hemorrhage, major hemorrhage is always a contraindication. So there are two cannulation types. So now the most favored one is single site bicaval bilumen catheters, and also dual site cannulas, which are routinely used across the world. We use quite commonly the dual site cannulas. Now let's understand the single site bicaval bilumen catheters. So as one can see, there is a single site that is in the neck into the interjugular vein. So from there, the single catheter is passed into, which goes into the superior vena cava, as well as which so it has got two ports over here, which acts as drainage cannulas. The return cannula is directing the jet of blood towards the tricuspid valve. The advantage is that it's a single site cannulation technique. So the incidence of catheter related bloodstream infections are low, and it leads to better patient comfort and helps in early and aids in early mobilization as well as physiotherapy, and it is a much more convenient to use. The flip side is that it is technically challenging. So you need an exact alignment of the return cannula with the tricuspid valve. So a fluoroscopic guidance is a must, or it can be done under transesophageal echocardiography. Dr. Sanjay, he does a lot of these cannulas, so he has been an expert in putting on these Avalon cannulas. And one more advantage is that the recirculation is as low as 2% if correctly placed. So Avalon cannulas are preferred because the recirculation is less, and also it leads to better patient comfort, and it also prevents the shunting effect between the IVC and the SVC that I will be discussing in the later slide. What do you mean by shunting effect? So these are the preferred cannulas, but these are very costly. The dual site cannulas have been in vogue since many years, and let's understand what are these dual site cannulas. So the most common cannula placement is femorojugular placement. That is, femoral cannulation is the one which aids in as a drainage cannula, and the jugular cannula is the one which aids as a return cannula. So here the recirculation is less. So the recirculation depends on many factors. So recirculation by definition is nothing but the oxygenated blood which is coming through the return cannula. Without going into the systemic circulation, it is again being drained out by the drainage cannula. So recirculation is bad. And the factors, one of the predominant factors contributing to recirculation is the position of the cannulas and how proximate they are with each other. Ideally, the literature says the distance between the drainage cannula and the return cannula should be at least 8 to 10 centimeter. And there are many other factors which can lead to recirculation. Among them, the position of the catheters is important. The return cannula, the drainage cannula, by convention, it should be placed at 2 centimeter distance from the junction of the RA with IVC, and the jugular cannula is at the junction of IJV with the right atrium. There is another cannula placement. So basically here the reversal of the flow, that is, the jugular is acting as a drainage cannula and the femoral is acting as the receiving cannula. So here the recirculation is quite prominent, not very much favorable. The femorofemoral placement is other placement wherein if the neck is not accessible, then one can go for the femorofemoral placement, wherein the drainage and the return cannula is through the bilateral femoral veins. As one can see, one cannula is longer. It's entering into the mid of the RA, and the other is below the junction of right atrium and the IVC, 2 centimeter below the junction of right atrium and IVC. The placement of the cannula is the key, as I earlier told. I hope everyone understood the placement of the cannulas. One can go for the placement of the cannulas either by the Seldinger technique or by the surgical cut down, depending on the comfort of the intensivist and surgeon who is doing it. The physiological considerations during cannulation is important. One of the key why the single site cannulas are preferred is because of this factor. In the case of normal individual, the above graph shows the fluctuations in intra-abdominal pressure. In a normal individual, in healthy patient, the fluctuations in intra-abdominal pressure is close to 4 to 5 centimeters of water during normal breathing. But in a case of severe ARDS, the fluctuations are close to 20 to 30 centimeters of water. With such high intra-abdominal pressure variations, this can lead to shunting of blood. In positive pressure ventilation, this shunting is predominant during expiration from IVC to SVC, and during spontaneous breathing, it is predominant from inspiration from the IVC to SVC. So these factors are important, which can have implications on the flows as well as the recirculation, especially in dual site cannulas. In single site cannulas, it is not much of a problem because the placement is through a single vein. And not only the cannula placement, but the cannula designs can also have implications on the overall ECMO circulation. The tip draining cannulas. So basically the tip has, it has got a single hole, the tip at the tip, which acts as the drainage as well as the return cannula. So during draining, it can drain the surrounding blood along with it. So the chances of recirculation are also pretty high with this tip draining cannulas. So the multi-site draining cannulas have been in vogue. So these, as one can see, there are multiple holes in the drainage cannula as well as in the return cannula. So this leads to the larger distance between the both, and thereby contributing to lesser recirculation. But again, there have been studies with MRI velocity scan, wherein they showed that the proximal holes, because of the Possel's theory, the proximal holes will receive more blood, and because of the venous collapse distal to that, there won't be any flow in the distal holes. So to avoid this, there are cascades that have been designed that will keep the vein away from collapsing, which have been used with the multi-site draining cannulas and aiding to the better ECMO circulation during the procedure. So this ends my lecture. So it was just a short intro into the various cannulation techniques and what is the physiology behind it, and when should we consider ECMO. Thanks for the opportunity.
Thank you, Vimal, for an excellent talk. You have dealt with almost all regards with whatever cannulation issues and how to sort them out with regards to VV ECMO initiation. Thank you so much for a wonderful talk. I would like to introduce Dr. Muralidhar for introducing our next speaker, Dr. Sunil. Everyone knows Dr. Muralidhar. He is a very well accomplished cardiac anesthesiologist at Narayana Hrudayalaya, Bangalore. He's got multiple publications to his name. He is very well read and widely publicized. Over to you, sir.
Thank you, Sanjay, for that kind introduction. And I would like to introduce Dr. Sunil, who is working with us as a cardiac intensivist. And he has a lot of experience with ECMO, ventricular assist devices, and echocardiography. Sunil, please go ahead with your talk on weaning VV ECMO, and we'll have the discussion at the end of that talk. Thank you so much.
Thank you, Dr. Muralidhar, and thank you, Dr. Sanjay, for giving me this opportunity. I would like to discuss about ventilatory settings and weaning of VV ECMO. So I have no disclosures. So we recently dealt with one patient. He's a 56-year-old male. He had chronic thromboembolic pulmonary hypertension with hemoptysis, who has undergone pulmonary thromboendarterectomy. He has developed reperfusion injury and bleeding from the right lung on the second post-operative day, planned to put on VV ECMO. So the X-ray on the left-hand side is immediate post-operative X-ray. In intraoperative itself, he had a blood, but eventually it settles on its own. And the X-ray on the right side is the second post-operative day X-ray, where the blood has been accumulated all over the lung fields. So which has made it as whiteout lung. So on the second post-operative day, the patient has been taken to the theater. They have inserted femorojugular venovenous ECMO. So as you could see, the drainage cannula is from the femoral side, and the receiving is from the jugular side. And this is what the ECMO console we use. And this is the oxygenator on the rightmost corner. Once the patient is taken back from the theater, the most important thing is to rest the lung. So we have to take care of the ventilation part. So while what is the most important thing which is to be thought of is the ventilation part will be taken by the extracorporeal circuit now. So our lung has to be rested. So thereby preventing ventilator-induced lung injury called Weaning. So thereby reducing sedation, immobility, and avoiding critical illness neuropathy. So the principally the sweep gas is used to titrate the desired carbon dioxide. A schematic representation of the ECMO circuit. Here you could see the oxygenator, which is the deoxygenated blood has been drawn from the patient and ejected to the oxygenator. You could see the membrane, thin membrane, where the blender is also attached. Now what's happening from the blood and the gas layer, the membrane is pretty thin, which will helping us out to get the oxygen into the blood and giving the carbon dioxide back to the gas. So thereby the oxygenated blood is pumped back to the patient. So the ventilator settings would be low level pressure control settings to reduce the Weaning due to alveolar strain. You should have a high PEEP so that the lung derecruitment and recruitment, which is causing atelectotrauma, will be reduced, and the sharing injury at the interface between the collapsed and the ventilated lung. So apart from low pressure control, high PEEP, low tidal volume is also important. So basically a lung rest or ultra protective ventilation as low as 4 ml per kg of predicted body weight can be achieved. And lower respiratory rate may also be considered to reduce the help of mechanical lung stress. Coming to FiO2, FiO2 of about 0.3 to 0.4 is sufficient to keep a saturation of SaO2 of more than 80%, which prevents atelectasis from the high lung FiO2. And in our patient, we did early tracheostomy because it needs, as our patient had bleeding in the lung, so it needs frequent toileting of the lung so that the early recovery happens. In addition to lowering the risk of ventilatory Willy, the use of pressure control allows to daily monitoring the tidal volumes as the patient improves, and the white lung will convert into a black lung. In other words, the complaint, as the complaints increases, we can even think about trials of desedation, and spontaneous breathing can be started. This is the typical ventilatory settings, as I said it previously. This is a snapshot of our patient which has been connected. As you could see, the oxygen has been kept around 30%, PINs of about 20, frequency of about 10, pressure support 10, PEEP of 10, and you could see the tidal volume of about 25 is getting achieved. So we managed this case for about 20 days by repeated bronchoscopy, and gradually it improved to a certain stage. So, we should think about weaning part as well. So even though the weaning has to be thought once the patient is put on VV ECMO, will be certain opportunities where you could think about starting the wean. Weaning is not a just 1 or 2 day process. It starts from the beginning of the initiation of the ECMO. So when to wean? So weaning can be commenced when the lung injury lung recovery has begun and lung rest is no longer necessary. So this is predominantly by patient underlying condition. So different causes and different severity of the lung disease will require different lengths of the time with VV ECMO support. So weaning is typically started when the patient lung compliance improves on the ventilator along with the improved chest X-ray. And this requires clinical judgment and careful monitoring of the patient's progress. So this is a slide from the ECMO guidelines. So as I said you earlier, which is most important is the chest X-ray improvement. Along with that, also has given a importance on oxygenation and ventilation. To assess the oxygenation, we have to the ECMO flows has to be reduced to 1 to 1.5 liters and check for the FiO2 requirements. If the FiO2 requirement is less than 60, PP is less than 10, and the FiO2 is more than 70 in intubated patient, and the PO2s are more than 70 in non-intubated patients if using with the normal mask, and if FiO2 of about 0.3 if you are using the high flow nasal cannula. In this, that will give us a readiness for the weaning process. For ventilation, we have to reduce the sweep gas to almost 2 liters and check whether the tidal volume is less than 6 ml per kg body weight, plateau pressure less than 28, respiratory rate less than 28, and most importantly, ABG demonstrate acceptable pH and PCO2 based on the patient clinical condition without excessive work of breathing. So this was the patient pre-op X-ray, and this was the immediate post POD day 1 X-ray, and this is POD 2 X-ray, which has become whiteout, and all the lung, alveoli has been filled with the blood. Upon frequent toileting of the lung, all the areas of bleeding has been taken out, blood clots has been taken out. Apart from the left lingula and the right lower lobe quadrant. So then again, we thought we did prone the patient so that what the gravity dependent blood in the lingula can come out. As expected, our all the lung fields have become white out because of the bleeding. So again, we kept doing the bronchoscopy day by day. Within a few days, it recovered. Like it looks like normal. So next would be how is weaning how to wean from VV ECMO can be performed. So usually weaning from VV ECMO can be done by reducing the sweep gas. At the same time, you have to increase the lung ventilation from the ventilator settings to maintain adequate carbon dioxide clearance. As decreasing the sweep gas, hourly ABG is to be done to check for the oxygenation as well as ventilation. So successful weaning is confirmed if the patient remains stable at sweep gas of about 0 liter per minute. I repeat it, the sweep gas of about 0 liter per minute for a period of 4 to 24 hours. And even a consultant discretion is also there. Like some people will be, they think at 4 hours itself, they'll try to wean the patient, decannulate the patient, and some institute till 24 hours. So note that in VV ECMO, that oxygen blender FiO2 need not to be weaned. As the sweep gas is off, the patient is off ECMO. But the recent ELSO guidelines has put a word that there is a way where before reducing the sweep gas, we have to step on do the reduction of the fraction of delivered oxygen from 1 to 0.2% with the decrements of 20%. We usually don't follow this because the carbon dioxide clearance is much more important for us. And the circuit blood flow does not need to be changed. However, when pulmonary oxygen has improved, there may be rationale to reduce the circuit flow rates with aiming to reduce access insufficiency. So thus facilitating diuresis and spontaneous breathing trials. So like IACT, the ACT or APTT, we usually target a ACT of about 140 to 160 seconds. Usually for 2 to 3 days we monitor ACT, then we'll switch over to APTT, which need not to be it doesn't warrant increase in the VA as in VA ECMO. In VA ECMO, we usually go up to almost 180, 200 seconds. But in VV ECMO, there is no need to increase the anticoagulation. Then our echo is not a mandatory here, but it can be used to look for the right heart function. So our basic VV ECMO targets are, we try to keep a hematocrit of more than 35%, PO2s of more than 50, saturation of 80, PCO2 in initial stages. We don't want the patient to breathe and struggle himself, so we keep it around 35. And once the patient, we are planning to wean, we'll keep it around 45, so that the CNS response to the spontaneous breathing will be triggered. And we keep a INR of less than 1.5 and a platelet count of more than 1 lakh. And you could see have depicted oxygen dissociation curve. You could see if you have a high hemoglobin, if the patient is hypoxemic in VV ECMO, we can transfuse, we can keep a hematocrit of about 40 or to 45 as well, because the high hemoglobin reduces the hemoglobin oxygen affinity, so that the tissue level, there will be a more oxygen delivery. So how we are going, how our peripherally inserted VV ECMOs are removed? So we have to explain the procedure to the family and the patient, and remove all the dressings. Sorry, clamp all the axis and return lines, power off the console, and so remove the cannula and allow it to bleed, because if any clots are there, any thrombus is there, it will come out. And apply the pressures on the puncture site with a sterile gauze, and apply the pressure for about 20 minutes. The patient remains to be supine and still for 4 hours, and the cannulation sites are monitored for bleeding. So we even have to do a lower limb ultrasound after decannulation, 24 to 48 hours after decannulation, to exclude any kind of venous thrombosis. So whatever the we thought till now, it doesn't apply for the central ECMOs, VA ECMOs, and cut down techniques, which has to be taken to the theater and it has to be touched by a surgeon. So this was our patient. As you could see, the cannula has been clamped and taken off. So these are my references. Thank you.
Thank you, Sunil, for that excellent overview of mechanical ventilation in VV ECMO and how to wean VV ECMO in patients who have had VV ECMO for respiratory failure. Thank you for that. And I would invite all the speakers, moderators, and panelists to switch on their video and join the panel discussion. Dr. Ratan Gupta, can I ask you to request you to lead the panel discussion?
Sure, sir. My question is to Dr. Nitya. So how do you cut down on the cost while doing tracheostomy? Do we try to re-sterilize the kits and use it? In Indian context, and cost becomes important.
Yes, sir. So usually what I have seen is this Greg's forceps a lot of people use because it can be autoclaved and reused. And also even the other the Ciaglia dilators also people do reuse it. But in our institution, we don't reuse, it's a single use. So, but I think cost-wise, if you go that Greg's technique, because the Greg's forceps can be reused multiple times and any guide wire can be used for that. So that is all is required, and a tracheostomy tube. So that can be cost saving. And also most of the time they say percutaneous tracheostomy is cheaper compared to surgical. But then I think again, it depends on the surgical OT charges of specific institutes. Some places compared to if you're using a Ciaglia technique with a blue rhino, and in the OT, if you're using open tracheostomy, in some places, OT charges may actually be lesser than the percutaneous tracheostomy charges as well. But then if you use a Greg's forceps technique, I think the charges will be less.
Yeah, I agree with you. I think the Griggs works quite well. It can be used multiple times. It can be used after re-sterilizing it. That same thing doesn't apply with the rhino horn,
Yes.
because the first time when you apply the supplied jelly and the hydrophobic nature, it goes in quite easily. Subsequently, when you try to use it, there's a bit of resistance. But I think in case you use a combination technique, we use a Griggs forceps for opening up the tracheostomy, tracheal opening, and then gauging how much has to be opened, and subsequently just use the rhino horn for sizing. That combination helps, and it works quite well sometimes. Of course, I think it depends on the individual institute and their policies. But I think sometimes this combination can be remembered so that it becomes more successful. And of course, you can reuse the kits as well. Yeah. Fine. That was my question to Dr. Nitya. And
I would like to ask one of the either Nitya or Rajavardhan can answer this. There is some sort of controversy regarding incidence of nosocomial infections with tracheostomy. One study says that there's 6-fold increase, and another study does not say that there's an increase in the incidence of nosocomial infection. So would you like to make your observations on this aspect of patient care with regard to tracheostomy?
Okay, I'd like to answer that.
Yes.
See, sir, most of what has happened is because of the definition perspective nowadays. If you go into any literature, most of the evidence is there before 2013. Once the CDC has come up with the definition, most of the studies are inconclusive after that. So clinically, what we see in routine practice is nowadays after 4-5 days, we start seeing the infection invariably in most of the patient in our ICUs. To be frank, okay, whatever I deny, but it is a fact we see every day. Okay, most of the time we see after doing tracheostomy, the incidence of infection will become better, maybe because of better suctioning, getting them out of sedation, they're able to breathe on their own. We see that there is a decrease in the incidence of infection compared to tracheostomy in the tracheostomy compared to regular ET tube. That is the fact which we see daily. But from the definition perspective, even if we see at the end of the month what is the VAP incidence in the ICU, they say hardly 1% or 2% if you see the statistics in our own hospital. Okay, so it's very difficult to rely on the statistics per se, but better to have a clinical judgment and go take a call for a tracheostomy.
Thank you, Rajavardhan, for that response. Any more questions for that?
Yeah, I would like to ask a couple of questions, probably to everybody on the panel or anybody who wants to answer. One is, do any one of you have any experience of extubating a patient on VV ECMO? Which I think is one of the questions. Second question is, when would you do a tracheostomy? We know that patients with VV ECMO respiratory failure would take about 3 weeks in the ICU, 2.5 to 3 weeks in the ICU. So is there any guidelines of when you want to do tracheostomy? Do you want to do it early tracheostomy and just, so that you can come down on the sedation and wake him up early? So anybody on the panel can give an answer to that. Sunil, if you want to.
Yeah, the second answer to your second question can be answered by me. Answer to the first question is a bit debatable. I've going through the ELSO guidelines. Some of ELSO members are doing survey on whether to do an early awake ECMO, extubate on the ECMO kind of thing. It's basically 50-50. It has not came to any kind of guidelines till now. As I said the second question, I would like to go preemptive on tracheostomy so that early toileting of the lung, especially a PT where there will be a red hepatization of the lung. So frequent toileting of the lung would benefit us for the to go into the weaning process. I think I answered some of the answers.
Dr. Arjun, I'd like to answer the first question. Okay, we do extubation on some of the patients. Okay, we have to choose the patient very carefully. Which patient you want to extubate on ECMO. Generally, what we do is after 2 days, when kind of things are parameting, we are able to achieve the goals of ECMO. Then what we do is we'll try to stop that sedation and assess the patient. Okay, if on ECMO goals, if patient is not having showing any sense of respiratory distress, come down on PSV. Then take a call about extubation. We have done for quite a number of patients. Okay, we might be able to establish our own case report series soon, but we are doing it quite regularly nowadays. But we should be ready. There's a possibility that some of them might develop increased work of breathing after extubation, maybe support them with HFNC or NIV intermittently. Just imagine a tracheostomy patient on VV ECMO able to communicate, able to alert, and sometimes even able to feed on VV ECMO. It's a big achievement. Okay. So making we extubating on them, it's going to make a lot of difference. Are able to speak, make a lot of difference in their care and management also. So some of the patients we are able to do it.
Thanks, Sunil. Thanks, Raj.
Any comments from Sanjay on this matter? And Vimal, maybe?
Yeah, it's an interesting statement, Arjun, because I think it depends on the pathophysiology we are dealing with when the guy goes on to VV ECMO. Now, if you had the guy like what Sunil had depicted in his talk, where he had a complete whiteout of a lung, which was a combination of both a reperfusion injury as well as bleeding from the parenchyma into the main airways. Now, in a situation like this, that would warrant a lot of bronchoscopy and toileting and hoovering out of the tracheobronchial tree. Use of cryobronchs also is something we resort to in these cases. So in these patients, getting them extubated with a lung like that, yes, it does not actually affect the numbers from an arterial blood gas perspective. However, it would affect the ease of toileting which you would have with either an endotracheal tube or a tracheostomy in situ with these patients. Secondly is, when the family members come in, they see a guy having a very seesaw breathing pattern because he's generating tidal volumes of under 50 ml. So that is a visually disconcerting sight, which might not be very palatable to the family, although it plays no role in the arterial blood gas for that patient. So I think if we judiciously choose the cases in which we tend to extubate them, I think it is something which is definitely a workable idea. However, in patients who've got large parenchymal bleeds, which are distorting the parenchyma and the tracheobronchial anatomy, it's probably safer to go in for a tracheostomy maybe by day 7, because you don't want to induce any mediastinitis in these people. And once you have a tracheostomy in situ, yes, they can easily come off the ventilator. And then you can do your toileting to your requirements. And then everything starts moving the right way.
That makes sense, Sanjay. Thank you.
Yeah, I do agree with what you said. It is probably disconcerting to see a patient struggling to breathe. Just you want to have awake ECMO and things like that. Sometimes doesn't look as good as we think. I agree with you.
Yeah, how does the coagulation play a role in deciding when to do the tracheostomy in this patient? Sanjay?
This question is...
I lost you there, Arjun. Ratan, can you repeat it?
Sanjay, my question was, how do we decide on tracheostomy with the background of a patient being on anticoagulation, and sometimes they can be quite coagulopathic, especially post-surgical patients. So
we normally would look for normal coagulation parameters like an INR of less than 1.5 and a platelet count of at least 80,000 before we consider a tracheostomy. If these two parameters are not in place, then we'd probably defer it. But generally, if you have an INR and a platelet count which is in that range, then we could easily do a tracheostomy with an ACT or an APTT ratio of 1.4 to 1.6 in VV or 1.6 to 1.8 in VA. That doesn't cause much of a problem per se. As long as your INR and your platelet count are okay, I think the rest of it shouldn't actually matter too much.
Thanks.
There is somebody asking, what about stopping? Do you guys stop heparin infusion when you are planning to do tracheostomy? Will the circuit not clot? That somebody is asking.
No, we never stop the heparin infusion at all. Even if we have an APTT ratio which is grossly abnormal, we still run a 0.1 ml per hour in the background. We never stop the anticoagulation completely. And basically, the perfusionists or the intensive care nurses are also monitoring the delta P on the oxygenator continuously. So that is pretty much an indicator if the clots are starting to form and we need to take some kind of evasive action.
Okay, I would like to ask Vimal, it's a question which always is in my mind. When you target the SpO2 or VV ECMO, we say that 85 to 92 is okay. But when we ordinarily ventilate patients, anything below 95 or 92, we get worried. So why is this difference between the requirements in VV ECMO vis-a-vis the other situations?
Yeah, so I do not have a literature to support the answer, sir. But permissive, so as a part of conventional mechanical ventilation strategy, we do avoid hyperoxia. And at the same time, in order to deliver the safe ventilator strategy, we do accept lower limits of the numbers, like 88 to 90%. But when it comes to ECMO, patient is probably on the other end of the spectrum, wherein the acidosis has set in, and we want to correct the DO2 VO2 mismatch at that point of time. So probably the targets are on a higher side, as most of the ECMO targets do state a hemoglobin of 10, 12, but we do go for restrictive transfusion strategies on a conventional basis, accepting a hemoglobin of 7. And accepting a saturation of 88% if it is there is no contraindication like pregnancy or other conditions. So probably in that aspect, I might think so, but I will be curious what others would consider appropriate answer for this question.
Any idea, Ratan, Sanjay, or?
Yeah, I think one way you can come down on the, let's say, keeping the FiO2 low, probably the direct oxygen toxicity would theoretically sound good, so that you can keep your FiO2s on the lower side. The other thing is, even if the saturation is 88 or 86, on VV ECMO, you can be sure that you can maintain that. Whereas when the patient is not on ECMO, any secretions, anything can significantly drop the oxygenation, and you don't have that kind of a safety margin when the patient is not on ECMO. So probably I think that gives you the courage to keep the FiO2 on the low side and target the saturation around less than 90, which you don't do on patients who are just on ventilator and not on ECMO.
Yes, yes. Any other responses?
I think if you look at the oxygen cascade per se, that pathway, if you look at what is the oxygenation which is required to deliver at a tissue level, if you look at that, it says around the average of 45 to 50, more than that is enough to cause a diffusion of oxygen cascade at tissue level. Okay. So,
tension, is it? What is 40?
Yes, millimeter of mercury in that PO2. If you look at the oxygen cascade, if you look at the tissue level, it is mentioned that around 45 to 50 is what is required to maintain the diffusion at the tissue level.
Okay.
Okay. Even though that PO2, when it comes, it might be 150, it will come down to 107. It will keep coming down during the various stages, but at the tissue level, that is the target.
Tissue level comes down to 10, even 10 at mitochondria, it's only 1 millimeter.
Yes, yes. So, see, our goal is to maintain what is required at the tissue level. More than that, that's what we are trying to target here. Okay. But in case of VV ECMO patient also, when you try to maintain this target, patient will be well sedated and paralyzed without any extra work of breathing. Basically, we'll be cutting down on the VO2 also, how much oxygen or demand a patient requires.
Yeah, that is one significant point. I agree.
Yes,
That's a very significant
so
point.
here we are cutting down on the VO2 consumption also, as well as the demand also. So that's where we are trying to balance it. Because achieving too much also, ECMO as a machine has its limitation. It can't deliver as much as we DO2 we want. Okay, basically it is about balancing VO2 and DO2 at the end of the day.
Right. Thank you for that.
So
Are
one
there
more
any-
point I wanted to
Yes.
debate or discuss was the role of echo during ECMO.
Right.
Maybe it's VA ECMO or VV ECMO. I think there is significant role for it to play. Looking at especially post-operative patients, if it is a VA ECMO, you can look at the pericardial collections, pleural collections, and the IVC. You can see that cannula placement. What do you have to say, Sunil? Can you elaborate on this thing?
Yes, sir. Of course. Like in VA ECMO, it has a definitive role. As you said, cannula placement and pericardial effusion, any kind of pleural effusion, which is hampering, causing any kind of hypotension, hypoxia. It has a definitive role. And while weaning also, we'll be checking the LVO, VTI, TAPSE, and E by E prime. All will help. But in case of VV ECMO, I don't think it has that much role as compared to VA ECMO. In VV, we are only concerned about now RV. So if the RV function is good and other parameters, hemodynamic parameters are okay, I don't think it has got not much role.
Okay, I think lung ultrasound probably definitely would be important in these patients as well. What the other members of the panel have to say?
Ultrasound is probably the lifeline in these patients. Any undue event, ultrasound will be quite handy. You can diagnose what exactly the problem is right from the fluctuation of the flows. It could be anything. It could be right from the cardiac tamponade to attention pneumothorax to hypovolemia. Or so you can instantly diagnose it with the use of an ultrasound. So any sort of a fluctuation, I think ultrasound examination is a must on ECMO patients. It will cut down the time in diagnosis, and also we will be able to pinpoint what exact measures have to be taken in troubleshooting this.
Yeah, that's very reassuring, Vimal. Yeah. Oh.
Arjun, are there any other questions?
Again, last question from my side. Vimal, I think you spoke about the bicaval, bilumen catheters. I very well know both me and you, although we work together, we've not put a cannula before. How anybody in the panelists? Anybody has? I'm sure Sanjay is the most experienced of the lot. Anybody in Manipal? Have you used bicaval, bilumen catheters for VV ECMOs?
No, we don't use it in our hospital.
Okay. Is it available in India, Sanjay? I remember
Yeah, we there are two. The Avalon is the conventional double lumen cannula, which is used in the West. It's incredibly expensive, so it's not yet made inroads into India. But there is an Origin cannula which is produced locally in India. However, there is a very big shortcoming in its fluted profile. So the Origin unfortunately doesn't come with a dilator set, which the Avalon comes with. So you have to make and use your IABP insertion dilator sets as an adjunct to get that Origin cannula in. The Origin has got a very blunt tipped edge versus an Avalon, which has got a very nice fluted profile at the end, which compares to your blue rhino in your tracheostomy, where you have a nice gentle curve and it just goes into your trachea. There is an Origin having a blunt tip and not having a set of dilators which comes with it, makes it a little bit of a challenge to get it into the vessel of the lumen of the vessel. But of course, it comes with a price tag. It's 1/10 the cost of an Alva.
So we continue to stick to IJV and
A conventional surgically inserted IJV and a femoral cannula is probably an easy escape route in an Indian scenario where Avalon is still not affordable.
And finally, the ideal way of doing it, do you think, do you have an ideal way of doing it? Is it IJV and femoral or femoral? Any advantage, disadvantage of either?
No. Like Vimal mentioned it in his talk, the distance between the tips in an adult patient should be at least 8 to 10 centimeters to avoid any kind of recirculation. Ideal scenario would be an IJV return and a femoral drain out. That would be ideal, but the options of a fem are also okay. If you're using an Avalon, you have an option of either putting it through the IJV as a single lumen, or you could put a side-on graft onto the subclavian and you can insert an Avalon through that. So there are multiple ways of doing it, but I think at NH, we primarily use IJV and a femoral route.
Thank you very much, Sanjay.
Ratan, any other question is there? Is there any other?
No, sir, nothing really pressing.
Any last comment from panelists or anybody else? Speakers?
Yeah, I think tracheostomy-wise, I think we've become bolder and bolder.
Right.
Previously, the things which you were thinking as contraindications, maybe a obese patient or a difficult tracheostomy or patient on even ECMO. Previously, when patients were on active ECMO, we used to hesitate doing any kind of procedure because of the anticoagulation.
Right.
Maybe it's thoracotomy or thoracostomy, putting an ICD or tracheostomy.
Yes.
I think those things have become better and better now.
Yes.
Definitely, I think technology is helping.
So during this, sorry, Arjun.
When it comes to tracheostomy procedures, I am very comfortable with regular conventional rhino procedure than the Griggs. Griggs is a bit gory, and it requires a little bit of continuous practice. It is not very simple. As Rajavardhan said, for the residents who are listening to this talk, probably you should be assisted by a senior consultant or a consultant in at least 20 cases of doing any kind of percutaneous tracheostomies. Have your own style and go ahead with it. So, I personally, I'm a big fan of bronchoscopic guided percutaneous tracheostomy. I think it's very safe, and the confirmation is much easier. As Nitya said, puncturing the posterior wall is also much lesser. So for me, bronchoscopic guided percutaneous tracheostomy is the most safest percutaneous tracheostomy procedure. Yeah, thank you.
Thank you so much. And I think when you're talking about weaning ECMO, I think bronchoscopy, prone positioning tracheostomy, the three things are having a definite role in that. And if there are no questions, I think it's time to go for our dinners. And Dr. Jayashree Sood, would you like to say something? Dr. Jayashree Sood is the CEO of Indian College of Anesthesiologists.
As usual, Dr. Murli, everything was so good. When you are the moderator, everything goes up so well.
Thank you.
And such a good interaction with the students and, of course, the faculty's experts. Thank you so much. Thank you so much, everyone.
Thank you. Thank you so much. Thanks for being with us. And on behalf of Indian College of Anesthesiologists, I would like to thank the moderators, panelists, and the speakers for joining us. Dr. Ratan Gupta, Arjun, Sanjay, and the speakers, Nitya, very well done, tracheostomy indications. Rajavardhan was speaking about controversies. Vimal was talking about cannulation techniques. And Sunil was talking about weaning ECMO. Thank you so much. So we come to the end of this session, and I would like to see you again and again. And before the dinner gets cold, I think I will say good night and we'll meet again. Thank you so much. Thank you, Dr.
Thank you, sir.
Jayesh. Thank you
Thank you
so
very
much.
much.
Good night. Good night, everybody. Thank you
Thank you
so
so
much.
much, everyone. And good night, everyone. And for all your permission, we are closing here. Thank you.
Yeah.
Thank you so
Okay.
much.
Bye. Bye. Good night. Good night.
Good night, ma'am. Good night, everyone.